Hi friends, welcome to classes by Lab Doctor. In today's class, let us discuss about how do we approach a case of hypercalcemia. You all know that whenever a patient has hypercalcemia, there are various causes for hypercalcemia which we have discussed in our previous classes. For that, to evaluate now the cause of hypercalcemia, we will have to take a careful history of the patient. We will have to examine the patient. We will have to see the clinical manifestation of this hypercalcemia. We will have to evaluate the risk factors for hypercalcemia. We have to see if the patient in any kind of medications. Is there any family history, etc. These were the various causes of hypercalcemia. Malignancy associated certain tumors like renal tumor, breast cancer, multiple myeloma, etc. They are associated with increased calcium levels. Could be because of the parathormone related proteins which they secrete. They can have the capacity to increase the level of calcium in the serum. Then there is parathyroid mediated hypercalcemia, wherein you have primary hyperparathyroidism, most commonly because of the adenomas in the parathyroid gland. Then you have the tertiary hyperparathyroidism, wherein the parathormone or the parathyroid gland is constantly under stress to release increased PTH because of the problems in the kidney. If the patient is having kidney failure, kidney transplant, etc., and that leads to increased calcium. Then you have this familial benign hypocalciuric calcemia that occurs because of a gene mutation in the calcium sensing gene. Certain granulomatous diseases like in sarcoidosis, tuberculosis, candidiasis, histoplasmosis, leprosy, etc. Patient can have the increased calcium level because of one is there is increase this alpha hydroxylase activity which is seen in the macrophages and the giant cell, and also that will help in the conversion of this 25 hydroxy to 125 hydroxy, which can increase the level of calcium. Certain drugs like thiazides, vitamin A, vitamin D, they can increase the level of calcium. And certain other endocrine diseases like thyrotoxicosis, adrenal insufficiency, pheochromocytoma, the milk alkali syndrome, renal failure, immobilization, all of these can cause hypercalcemia. Hypercalcemia is often asymptomatic in early stages, and also in mild hypercalcemia there might not be much of the symptoms. Symptoms will vary depending upon the cause of hypercalcemia and also for how long this problem of hypercalcemia has been present. Like I have told you, like in case of primary hyperparathyroidism, patient will have increased calcium, most commonly because of a parathyroid adenoma. So in that cases, what happens? Patient has stones, so he can have renal stones, nephrocalcinosis, because of which he'll have polyuria, polydipsia. There will be abdominal pain, so that is abdominal groans, so patient will have constipation, indigestion, vomiting, nausea, peptic ulcer, pancreatitis. Patient can have psychiatric issues, so it's called as psychic moans. Patient has lethargy, fatigue, depression, memory loss, psychosis, personality changes, confusion, coma. All this happen because calcium is a very important mineral which is required for the nerve functioning, and it has an important role in the activation, in the passing on the neurotransmitters through the synapses, etc. So all the cognitive functions can also get affected. So whenever there is hyperparathyroidism, primary hyperparathyroidism, the patient will we say that the psychic moans, abdominal groans, there are stones, and there are changes in the bones also. So this would be the clinical picture. And also because of hypercalcemia, various other symptoms can also come. Like I've told you, digestive issues. Patient can have nausea, vomiting, constipation, poor appetite, gastric ulcers, pancreatitis, etc. He can have kidney problems. There could be kidney stones, increased urination, etc. There can be muscle and bone issues. He can have muscle weakness. There could be muscle cramps, or there can be even fractures. Brain issues, cognitive issues, drowsiness, confusion, fatigue, trouble focusing. Heart issues can come, a fast beating heart, a fluttering heart, arrhythmic heart, pounding heart. All this can happen because of increased calcium. So now how do we approach a case of hypercalcemia? So whenever there is hypercalcemia, that is when the total calcium is more than 10.5 milligram per deciliter or more than 2.6 millimoles per liter, or the ionized calcium is more than 5.6 or 6 milligram per deciliter. So we will have to carefully take the history and we have to do the physical examination of the patient, focusing on the clinical features. What are the clinical features which we discussed now? What could be the possible causes which we again discussed, and what are the causes for hypercalcemia? Is the patient on any kind of a medication, and is that causing hypercalcemia, etc. So later, if at all the patient was any kind of a medication like thiazides, vitamin A, vitamin D, we will have to recheck the patient after some time. We have to recheck the calcium at a later date. And we also measure the intact parathormone level. So this parathormone level, this can be normal or high. Suppose if the patient's parathormone level is normal, comes as normal or high, what are we going to do next? We are going to check his 24-hour urinary calcium. Suppose when we do the 24 hours urinary calcium, patient's calcium level in the blood is more, patient's urine calcium is very less. That suggests it could be a case of familial hypocalciuric hypercalcemia. Suppose when we do the urinary 24-hour calcium, and suppose it also comes high. So the patient is having high calcium in the blood, high calcium in the urine. So that could be a case of hyperparathyroidism, primary or tertiary. So we need to do the scan, or we might have to even surgical intervention and take out the parathormone. So that is how we will go about in case if the PTH is high. Urinary calcium. This calcium which is excreted in the urine increases in the urine also in cases of hyperparathyroidism, and in cases of renal diseases, in sarcoidosis, multiple myeloma, vitamin D intoxication, thyrotoxicosis. So all this, usually the all cases of hypercalcemia usually have increased calcium also excreted in the urine. Whereas decreased urinary calcium can happen in case of, I've told you, in familial hypercalcemia, in vitamin D deficiency, hypoparathyroidism, preeclampsia, acute renal failure. If there is any problem with the absorption, like in celiac disease, PRU, steatorrhea, etc., then there can be less of a calcium in the patient's urine. So this was familial hypocalciuric hypercalcemia, whereas the patient is having a defect in the calcium sensing receptor gene mutation. In the second scenario, you have detected hypercalcemia. The levels of calcium in the serum are high. You did an intact PTH. The level of PTH is low or suppressed. So there are few conditions which can have hypercalcemia with low PTH, that is parathormone independent hypercalcemia. So these are not dependent upon the parathormones. So what are those conditions? Usually it will be malignancy associated hypercalcemia. It could be your lung tumor, it could be a multiple myeloma, it could be a breast tumor, it could be a sarcoidosis, etc., wherein there will be hypercalcemia, but then the parathormone level will be low. So in all these cases, the calcium level will be high, but the parathormone level will be suppressed. So I have told you that, in malignancy, in certain malignancies, like in case of breast cancer, lung cancer, multiple myeloma, certain malignancies of the head and neck, in gynecological malignancies, what happens is there is increased osteoclastic bone resorption. These tumors, the tumor cells, these cancer cells are going to produce something which is similar to parathormone, that is called as parathormone related protein. They are similar to parathormone related protein. So they have a similar functions as the parathormone. So because there is increased secretion of this parathormone related protein, it will behave like a parathormone. It will increase the resorption of the bone, so it will increase the calcium in the serum. It will increase the reabsorption of calcium from the kidney, so the calcium level is going to rise. It will increase the absorption of calcium from the intestine. The calcium level is going to rise. So this is a case of parathormone independent hypercalcemia, but this is because of the secretion of hormones or proteins which are related to the parathormone. I have also told you about the granulomas in sarcoidosis, tuberculosis, fungal diseases, histoplasmosis, etc. There will be a accumulation of the inflammatory cells. There will be macrophages, epithelioid cells, giant cells, etc. So what these inflammatory cells will do, they have this presence of 1-alpha hydroxylase enzymes, especially in the macrophages and giant cells, which form the granuloma, and the 25 hydroxy vitamin D is converted here to 125 hydroxy vitamin D without any control. So when this vitamin D is increased, there is increased level of calcium, there is increased absorption of the calcium, that can cause hypercalcemia. So this is also parathormone independent calcemia. Here there is no effect of parathormone. It is all because of this vitamin D or this alpha hydroxylase, etc., which is causing hypercalcemia. So these were the malignancy associated hypercalcemia. So if the malignancy workup is negative, so you found that patient and you found that patient has hypercalcemia, you did the PTH levels were low, so first thing you thought whether it could be something which is not related to the parathormone, so you started working up for the cancers and you could not find any risk factors, etc. There was the whole workup for cancers were negative. Then what are the other causes wherein calcium is high, the parathormone is less, or parathormone independent hypercalcemia can also occur in hyperthyroidism, in adrenal insufficiency, in acromegaly, etc. So in hyperthyroidism, what happens is there is increased resorption of the bones because of the increased osteoclastic activity, and that can lead to increased calcium. In pheochromocytoma, there is increased catecholamine levels, or there is a secretion of parathormone related peptides, which can again lead to increased calcium. In adrenal insufficiency, what happens? There is a reduction in the glomerular filtration rate only, and the mobilization of calcium from the skeleton is also happening. So that can lead to hypercalcemia. In acromegaly, this growth hormone can activate the vitamin D, and that can cause hypercalcemia. So these are all parathormone independent hypercalcemia, wherein there is hypercalcemia but the parathormone level is low to suppressed. Whenever you find out that there is an hypercalcemia, you have to evaluate the patient first. You have to take the clinical history. You have to find out what could be the possible causes with his history, family history, is he on certain medications, etc. Then measure his PTH, because we will broadly classify it as PTH dependent and PTH independent hypercalcemia. So suppose if it was PTH dependent, you will definitely get a PTH which is high or normal. Then check his 24-hour urinary calcium. If the urinary calcium is low, that suggests more of a familial hypocalciuric hypercalcemia. Suppose when you do the 24-hour urinary calcium and that is also high or normal, that suggests more of a hyperparathyroidism. If it is suppressed, first you work out the whether it could be because of certain malignancy, see for the risk factors for malignancy, and find out whether it is because of any kind of a cancer. And if the malignancy workup is negative, then you search for other causes like other endocrinopathies, etc., which can also lead to increased calcium, which are not parathormone dependent. This is how we will evaluate a case of hypercalcemia. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.